Okay, thank you very much, Stephanie and Doreen. So I'm going to kind of connect everything back to our coordinated access system and by name list here in Durham. Here at the region of Durham, we have made a commitment to be housing focused. So we think it's important in all of the presentations that we do to bring it back to our coordinated access system and how we're taking some of the things that we're learning and applying them to housing models. So this is just a quick overview of the coordinated access system that we have here. So on the left is just an infographic of how our coordinated access system and by name list work. We partnered with the Built for Zero Canada campaign in 2019. And then we spent a lot of time talking about coordinated access and the benefits of having a coordinated access system and by name list, but we didn't have any real action tied to those conversations. Then came the spring of 2020 with the COVID-19 pandemic, and our community kind of doubled down our efforts to be housing focused. And one of the ways that we wanted to demonstrate that was to implement our by name list and coordinated access system. So we made the decision, I believe it was in March of 2020. Then just a few short months later, in July of 2020, we had achieved our quality by name list. And then a few months after that, we achieved our quality coordinated access system. So that was in October of 2020. For the hub models, they really started as a COVID-19 response or crisis response. So when the pandemic hit and businesses and organizations had to start closing their doors to adapt to the way that they were providing services, we came together at our advisory committee to try and figure out how we could continue to provide services to a vulnerable population in a really easy way. And so what we had come up with is using a hub model. So we started with partnerships that we already had in the community who were able to provide staff at the hub model. Another critical part of our COVID-19 response was to use the hubs as a screening point and testing location for COVID-19. And we implemented a direct pathway from the hub locations to our isolation and recovery program. So they started really as an emergency response to the pandemic. Then once we made the decision to recommit to being housing focused, we looked at the hubs as an opportunity for us to implement coordinated access and by name list and use them as really low barrier community access points for the intake process. So the hubs have a very high volume of people, especially during the pandemic when a lot of things were closed. We were able to leverage those locations as a starting point for intake into our by name list and coordinated access system. Another benefit of those hubs is that a lot of the agencies that were on site already had experience using HIFIS and had experience completing VI SPDATs. So that made testing out our coordinated access system much more efficient and effective. So multiple services in one location helped us in several ways. The first is that as an access point, it was really effective because it really is the no wrong door approach. So somebody could be coming to the hub to access the clinic. Somebody could be coming to the hub to meet with their Ontario Works caseworker, could be coming to the hub to meet with a peer worker or meet with the harm reduction team. No matter how you get to the hub or what services you're coming for, it's an opportunity for us to engage about the by name list. It's also a very low barrier location that people were already familiar with. So people were already familiar with the backdoor mission and comfortable coming there for services. So then introducing more services there and having the conversations about the by name list, it was already in a setting that people felt comfortable in, which we think is really important. Another huge benefit of the hub and using the hubs as an access point is because of the high volume of people and the number of agencies that are involved at the hub, it's much more effective at keeping people who are on our by name list engaged so that they don't move to inactive. And they're also able to help locate people who don't have contact information when they're matched to a housing resource. So let's say I don't have any contact information and I'm matched to a housing resource in our community today from our by name list. The hubs are able to send the word out through the hub locations that everybody is trying to locate me so that they can let me know that I'll be receiving an offer of housing. This is just a quick snapshot of our data. It is only current until August. And so when we took a look at this data, I'm sure that this is not something that is unique to us here in Durham. You hear in the media, you hear in the community, a lot of anecdotal stories about how unsheltered homelessness is skyrocketing and all of those things. So when we took a look at our by name list data, it didn't really match with what we were hearing. You can see that really from January, it's been fairly consistent. So then we took a bit of a deeper dive specifically into unsheltered homelessness data on our by name list. And again, what we found is that we're averaging about 39 people on our by name list every month who identify that they're unsheltered, and that too has really remained stable since January. We average about 10 new people being added to our by name list every month who are unsheltered. And right now our outflow is also about 10 each month. And for us to really start seeing progress in reducing unsheltered homelessness, it takes about 11 outflow points to reduce our baseline by 1 each month. So that is also something that we're working on. But all of that is to say it wasn't really fitting what we were hearing in our community. This is just how we track data through all of our street outreach initiatives here in Durham. And I wanted to draw your attention to the bottom two here. So the percent of households that are on the by name list, and then on the flip side, the percent of households that aren't on our by name list. And we figured that we could mobilize the hubs to help us start tracking some of this data in a better way. So use the hubs as an opportunity to engage. So again, that low barrier engagement and the peer engagement that's through the hubs. So we can track engagement over time. So it provides a really great opportunity to start running some PDSA cycles specifically on engagement. So what's the average length of time that it's taking for first engagement before somebody is interested in wanting to be added to the by name list? What is the average number of engagements that it takes? And then you can start running some improvement projects, to try and shorten the length of time and the number of engagements. More importantly, though, for us right now here in Durham is an opportunity to track information and data for people accessing hub services who aren't on the by name list, and so that we can learn why they aren't on our by name list. And one of the most important findings that we've had more recently is that we know 32 people specifically. We know who they are, we know what their names are, we know what their stories are, and they aren't on our by name list, and they aren't on our by name list because they aren't able to provide informed consent and aren't able to engage because of significant health barriers. So some significant mental health and addictions concerns specifically for this group of people. It's making them not able to engage. And then we're able to use that data to advocate for what our community needs. It's much more effective to have conversations when you have numbers included in your asks for service instead of talking in kind of those anecdotal things about this group of people or this is a gap in our community. We now know that there are 32 people that we need to plan a support service for. The hubs are also an opportunity for us to build partnerships to increase capacity in our community. So again, we started small. We implemented the hub as a response to the COVID-19 pandemic and used existing partnerships, and then we continue to build out the services that were available based on identified needs. We then engaged the executive leadership of those partnerships in a new and formalized way. So here in Durham, we established our Health, Homelessness, and Housing Committee, which is now a standing committee under our Durham Advisory Committee on Homelessness. Then, as always, data. You need to use data and identify how you're going to collect data in a standardized way to quantify what resources you need from other sectors. So going back to my previous example of the 32 people in our community, we now know what those needs are. So we can go back to the health sector to say, these are the support needs of this group of people. There isn't anything available that matches the needs of these people, and we need 32 to support 32 people. So let's say in your community, there's a mental health case management team, and you know their caseloads are a ratio of 1 to 10. If you have 32 people, you know you need to ask for 3 of those dedicated workers for this sector. And then we're also continuing to build on what is working at the hubs to integrate these wraparound supports into housing programs. So again, going back to Durham as being committed to remaining housing focused, there are a couple projects that we're now taking all of the things that we've learned at the hub model and expanding it to housing models. So the first is our Oshawa microhomes pilot. So that's a pilot that's happening here in Durham. We're planning for occupancy this December. And we used our Health, Homelessness, and Housing Committee to co-design the support model for these units. We partnered with CMHA Durham for primary health supports in connection to community health supports, a partnership with Lake Ridge Health for dedicated mental health and addiction supports for these units, and then partnered with our Housing First program operators here in Durham. And so we're using a case conferencing model and shared. So we're going to use the SPDAT as our primary tool, and that information will be shared with all of the partners involved so that we can provide the best wraparound supports for the folks that are living there. Two other initiatives. So right now we're also developing a consenting case conference model for residents who haven't been able to engage due to significant health barriers. So again, that group of 32 people that I was speaking about earlier. And we're developing a consent specifically so that we can bridge between health information and information that we share within our homelessness support system to make that process easier. And then our ultimate goal after we have our case conference model set up is to develop a specific support model to address that gap for this population. So we know that there isn't anything that currently exists in Durham that is able to support the needs of this group. So we've seen many of these people cycle in and out of the health system and the homelessness system. So we know that we need to do better at creating either a new or bolstering an existing program and service that we can use to better support that group of people. And that is it for my leg of the presentation. Thank you very much for listening. And we are very much looking forward to answering any questions that you may have.